Okay, so our next panel, considering how much we were talking about cost in the last one, I think timing is right. So Arnie Milstein will be chairing this call, Cost, Care, and Access.
Great, thank you. Before I introduce our panelists and the particular vantage point that through which they will allow us to begin to understand the challenges of improving cost, quality of care, and access in rural America, I thought I'd just level set by just summarizing a few national statistics comparing rural health and urban health in the U.S. As I go through this list, you'll hear 7 things that actually that strongly suggest that things are at this point much more advantaged in urban areas, but then 3 statistics that highlight ways in which, at least as of the last time the federal government looked at these statistics, the situation was actually more favorable in rural areas. First, as we know, that briefly, the last federal stats on number of physicians per 10,000 people showed that the numbers were less than 50% in rural areas, and if you break down that distribution, it's about an 85% lower frequency or rate of per 10,000 population of medical specialists. The percentage of adults who describe their health status as fair or poor is about 15% in urban areas and about 20% in rural areas. The percentage of adolescents who smokes is roughly double in rural areas, 11 versus 5%. The Medicare beneficiaries without drug coverage, this is generally due to income challenges, is 43% in rural areas, considerably more than the 27% number in urban areas. The percentage covered by Medicaid is modestly higher in rural areas, 16 versus 13. One of the things I'm going to be asking our panelist, Mark Duggan, to talk about is the fact that if you look on the federal exchanges, generally the premium costs for the exact same policy and focused on the very same actuarial risk tier, the insurance premiums tend to be order of magnitude about 25 to 30% higher in rural areas. And then I think on the positive side, the last time the federal government measured it, all this being true, the male life expectancy in rural areas was about 2 years longer than it was in urban areas. The female life expectancy was also about 2 years longer, and the percentage of dual eligible Medicare beneficiaries, people who were both elderly and poor, was 70% in the urban areas and 30% in rural areas. So generally statistics disfavor rural areas with some exception. To address this problem, we have panelists who've examined and in some cases personally experienced rural health care, who will explore it from 3 very different vantage points. Alan Glasseroff, who's my first panelist on my left, is a primary care physician and a Stanford faculty member who has spent most of his practice career in Arcata, California, a town with a population of 6,000. Is that right, Alan? Yeah, 6,000. 7,000 more students that come. Just 6,000 residents and then 7,000 seasonal students. And Alan is nationally known for his efforts to cohere doctors in both rural and then once he's come to Stanford in urban communities in the job of lowering the cost and improving the quality of health care. And also, as he will describe, he's also thought deeply and been active in thinking about how one might use not just health care, and in particular primary care, better primary care as a lever for improving health in rural areas, but also thought deeply and been personally involved in successful efforts to mobilize minimally funded state public health departments and county health departments to do something about it. To his left is Brent James. Brent is really an internationally known figure in managing healthcare performance in all of its dimensions. I suspect, and I don't want to disrespect anybody in this room, but I suspect Brent is the only person in this room who has spent a substantial fraction of his youth both driving and repairing tractors. If anybody would like to challenge Brent, please raise your hand. I asked Brent, where he grew up, trying to think about how small was the town, and Brent's response to me was that he grew up about 40 miles west of Blackfoot, Idaho, to give you a sense of his experience of rural life and rural healthcare before he went on to a very different career that's eventuated in him really being a national figure and thinking about how one brings advanced statistics and human psychology to the task of improving the value of healthcare. And his left is Stanford professor and head of CPRA, Mark Duggan, who has thought deeply about yet another lever, which is the use of public policies, particularly as they affect health insurance, but perhaps also some public policies that affect healthcare providers in rural areas. I should say that that Brent is someone who, as you probably know, works for Intermountain, has worked for many years as sort of the what has been described as sort of the secret jewel of Intermountain Healthcare's prominence in all national statistics on cost, quality, and access. And he did it, from the vantage point of a mission-driven healthcare in Utah, that operated a full scope of healthcare services and also operated a substantial health insurance plan. So it was a vision that many imagine the U.S. might move to, in which healthcare delivery systems are actually accountable for cost, quality, and access. So I said, panelists, we're going to be dealing with an audience after lunch and also people who may have been cognitively saturated by about mid-morning. So as each of you speaks for 15 minutes, please, if you could, for the sake of cognitive absorption, organize your comments around 3 key observations that then might spark a dialogue among the panelists and with you, the audience. Why don't we begin with Professor Glassroff?
So Arnie invited my wife and I, and she was the public health officer of our rural county, and I was the medical CMO of an independent practice association, to come to Stanford at the end of 2011. So in thinking about talking about this, it was sort of a walk down memory lane, and very moving to me last night, because I got back in touch with 28 years of my life, which I miss greatly. I'm actually living there again. So I wanted to start. I'm going to show you a series of pictures, and this is the road into Humboldt County, but from the Humboldt side, and you can see a freeway. That's a 2-laner. This is Highway 101, and I reversed Lynn Gallagher's path. That I grew up about 20 minutes from Stony Brook, and ended up living in a rural place. So I understand the need to change what you're doing at one point. I use this slide to just explain it's a rural place. Parts of it are true frontier rural, off the grid people, no phones, no cell towers, no high-speed lines, none of that. And then there are places that are also rural, but are cities of 20,000 people. And the county itself is the size of Connecticut. in terms of thinking of a state. And it has 130,000 people, of which maybe 40 or 50,000 live around what's called Humboldt Bay, which is Arcata to the north and Eureka to the south. And when we drove into town for the first time, it was Eureka. I found it, though it's a very poor community and it's not the prettiest thing to drive through. So my life was, we went up there to flee academia and flee the city because we trained in San Francisco at UCSF, and to start a life, have a family, and make it work. About 1995, we moved in 1983. So 12 years after I moved there, I found myself being asked to start a fledgling independent practice association called the Humboldt IPA to deal with the onslaught of managed care working its way up the coast and generally dividing and conquering. And we ended up with an organization that had the entire provider base of a county, and then my job was to keep us out of trouble with the Federal Trade Commission for restraint of trade. And it's a county that's poorer than the rest of the state and has a lot of health challenges. And I have some data from 2011. I didn't update the slide because this is when I was working there, so I figured tell the story that I know. And you can see, mortality was, there are 58 counties in California. We were 49th in terms of high rates of mortality. We were 28 in morbidity, illness, and then health factors themselves. Health behaviors were 40 out of 58. A lot of substance abuse, a lot of obesity. Poverty there is generally white, not, though there's a strong Native American Indian population, and now a rising Hispanic population. But clinical care by 2011 was 22nd in the state, which I thought was kind of a victory, but it also tells the tale of clinical care, doesn't remotely tell the story. So the things I'm going to talk about, my three, are things that evolved over the course of a story. And in 2002, we started implementing the chronic care model countywide. And the justification from my board of directors was keep us out of trouble with the Federal Trade Commission, and there's this exemption you can get if you're clinically integrating work. And because you're not supposed to have more than 30% of the providers in an area to be in a safe zone, and we had 100%. So we built the chronic care model out with a special emphasis on self-management. And Lynn's comments about New Mexico, I thought, were really dead on in terms of people want to self-determine. And turns out healthcare is largely about self-determination too. There's research which is being affirmed again recently that diagnosis and treatment is about 10% of outcome, and individual behavior is 40%. So we really focused on how do you build self-management, and built a community movement around a program that was first developed at Stanford by Dr. Kate Lorig, called Chronic Disease Self-Management Program, and it's a peer-led, group-based self-management program. And we ended up with the highest penetration of people having graduated the workshops, it's about 16 hours in total that people attend to learn how to live with chronic disease. And we got 3% of the entire population of the county through by the time I left in 2011. I haven't kept up with the numbers, but it's quite high. And the faces you see on the left are the leaders of the community leaders who led the groups, and they were all people who volunteered their time. And our job was to feed them lunch occasionally and dinner and pay for their transportation. And the slide on the right is the buttons that they gave out to the people who graduated the program. We also, through the Humboldt Diabetes Project, which was a project that was funded by the California Healthcare Foundation, talked about, we started peeling the onion of what does a chronic care model look like in a community. And we started out the way everyone usually does, by building registries, noticing gaps in care and measuring it. And then finally, the concept of a planned visit. And as a clinician, I maintained my practice the whole time I was there. Patients would come back. I'd say, let me see you in 3 months, and they'd come in, and I'd say, why are you here? And they look at me and go, I don't know, you told me to come. And then I would sit there, with a paper chart in my lap and say, how are the kids? So what I did was hire a work-study student from the university to pull my charts and measure my care of diabetes, which was surprisingly not as good as I expected. And then I shared that data with the community, and out of that came a challenge to everyone else to share their data, and we ended up building a community-wide web-based registry that relied on people downloading PDFs about the current data for their individual patient, and then faxing it back to the IPA. And we would get that piece of paper, and for $10 an hour, we hired somebody to do data entry. And then by the following day, it was an updated PDF on the registry, and then we could measure things in aggregate. And what ended up happening with that work over an 8-year period of time was a 29% drop in death due to diabetes in the county, as measured by the public health department in the state, looking at death certificates. And you say, well, things got better in terms of diabetes care, the meds improved, so big deal. But it was unchanged statewide in the same interval, so something different had happened. And then self-management grew, and we built this whole movement around care management, stress, and self-management. And that, for me, I had type 1 diabetes that I developed right after I arrived in Humboldt. And so I was really passionate about self-management because nothing I had learned in school taught me to live with type 1 diabetes. And the patients that came to me are the ones who taught me, so I really believed in that. And then we moved further and said, well, there are people that are still struggling, and we developed a program with Arnie's help, getting us the chance to do it, with the public employee retirement system in California that built a program called Priority Care, that was how do you manage the 5% that costs 50% of the money. And again, it was focused on self-management, use of community health outreach worker type folk, training them, empowering them, and tied to the chronic disease self-management. So it's sort of if you look at this slide, it's working from the beginnings of population health to segmenting the population, all in a rural area. And I enjoyed going to statewide meetings because we were outperforming the rest of the state by a lot. So the notion of these poor communities that can't take care of themselves, there are actually a lot of advantages in rural areas. This is where where the patients were in the county, and just to give a sense of the geography. I have this slide up there. And then this is the last slide, which is where the work was at in 2010. We received grants. A grant from the Robert Wood Johnson Foundation called Aligning Forces for Quality. And it was the state of Wisconsin, the state of, large parts of Michigan, Boston, Washington State, large urban areas like Cincinnati and Detroit and Cleveland and Memphis and Little Humboldt. We were the kind of the little engine that could. And we think about no resources, nothing going on in rural communities, but look at this thing. And I don't ask you to follow each arrow, but it's the complexity of what happened there. And why did that succeed? Why were we able to do that? It turns out rural communities have tremendous advantages in terms of cohesion, relationships, the ability to work across sectors. My wife was the public health officer, and I was the CMO of the medical community, and our pillow talk was unusual, to say the least. And we were able to bring everything together in an amazing way. We did, Lynn mentioned, those, I don't think you used the name Project Echo, but using telemedicine to help rural areas. Well, right now there's sort of a state-of-the-art program around palliative care called Resolution Health. That's an Echo project, and It's bringing, home-based palliative care in places that are completely off the grid. And it's an amazing program. I traveled out to learn what I could learn from other places and then would bring them back. But the community now, and I'm back there and I'm getting an update and I'm getting back involved. And I'm being forgiven for having left, which was a close call. At some point, people were very angry that I left. But it was worth coming here because it's been a tremendous opportunity to do the work that we did here. But what's happening in the medical community is the specialists are now almost all owned by a large hospital system. And they used to be independent docs who were committed to the community. Now they're less committed to the community because they come and go. And then in primary care, the private practices have kind of blinked off, and it's largely concentrated in a very excellent safety net. But again, the docs come and go, don't stay 30 years. We have the spouse problem, and it's not truth or consequences, but it doesn't have the employment opportunities that it might. And the recruitment around saving the community, and I have played a role in this, is sort of, it's not, oh, woe is me, who's going to turn the lights out, who's the last to go and turn the lights out, but rather let's create the most exciting practice environment as a lure to the young graduates leaving medical school, leaving nursing school, to want to practice kind of state-of-the-art models of care, which utilize team care, community health outreach workers, raise the role of medical assistants to be impaneled paraprofessionals rather than simply people carrying out tasks. There's a career growth, a career ladder that people can go up. There is a community college nursing school. And we get Stanford medical students who rate the primary care experience the top part of their last 2 years. So my point overall is that while there are challenges in rural areas, there are also tremendous advantages in terms of relationships and cohesion. The word tribe was used, and I think Humboldt is definitely a tribal place, for better and worse at times. But I'm going to stop there and then hand off, but thank you very much.
Just while Brent's standing up, I'll tell you that Brent James, as of mid-January, is now a professor in the Department of Medicine at Stanford. And Brent, are you mic'd up or not yet? So, Brent, I want to, as you're warming up, I just want to say that, when a lot of people look at the great health stats for the state of Utah, they say, well, gee, the health habits, are so much better. But what I know from one of your colleagues who speaks here at the Graduate School of Business, Greg Paulson, is that even after you adjust for the fact that health habits are better in Utah, the healthcare system stats and health stats relative to other states still look quite favorable, and health spending stats also look quite favorable in the state of Utah. So, the major force in making that happen, with all due respect to the University of Utah, was Intermountain Healthcare. And Brent, how did you do it? How did you and your colleagues do it?
I want to talk about this from a rural health perspective. I'm just building on what Lynn said as I listened to her. Yeah, I grew up 40 miles out of town, and town was 3,000 people, guys. That was a big city. I jokingly said it was my parents and me and a whole bunch of animals. I don't count my brothers as humans. So, my dad, he was from a cattle ranch, well, horsing. They raised horses, actually, for most of his life for the U.S. Army and for other ranchers and rodeo strings. Up north of the Great Salt Lake, it was 20 miles to Park City. Park City had about 20 people. It was then 40 miles, 40, maybe 60 to Snowville. We were up to about 50 people. Then it was another 60 to Tremont, and there were up to 1,500 people. And the big city, Logan, Utah, was about 120 miles away. We were way out in the country. We were poor. We were dirt poor, and I didn't know it. And it was a wonderful life, to be honest with you. I sometimes wonder if I've cheated my children by not letting them experience the same exact thing, in all serious truth. It was a wonderful life out in those areas. I'm going to tell you how we did it in a particular system, though, from that rural perspective. Yeah, a little bit of the layout where I've worked for the last 30 years. Wasatch Front, 80 miles long north to south from Ogden, Utah to Provo, Utah, Salt Lake anchoring the center. But about 80% of the population of the whole region lives in that one corridor, one valley wide, about 30 miles wide. Very urban along the Wasatch Mountains, the site of the 2002 Winter Olympics. Boy, you get outside of the Wasatch Front and it gets really rural, really fast as soon as you pull out. Now it is expanding out. We're seeing a lot of growth up in Summit County around Park City, some growth down to the south, especially in Utah County, down around Payson, Utah, Provo, Utah. So it's expanding, the state's growing rapidly. But you get these two mixed systems, really, of true frontier regions, or close to it, if not frontier, and then highly urbanized. Of Intermountain's 22 hospitals, 9 of them in urban areas accounted for literally 95% of all inpatient admissions. The other 13 were small rural facilities, very often critical access facilities, the only care available. I very often thought of them as big clinics with a few hospital beds, which is a pretty accurate description of what goes on out there. The trick, just one slide and a couple of principles maybe. I was going to argue that there's a real benefit from being part of a system. It was mission-driven for Intermountain. We didn't rely so much on government as we relied upon the system as a whole. There were financial benefits. It meant that those small facilities got the full benefits of shared purchasing on a broad scale. It reduced their cost of operations. Very much lower costs associated with access to capital. If you had to borrow money to build a new facility or something like that because they were part of the bigger system, for example. Shared administrative services on a broad scale, especially the HIT chunk that you could directly extend out. And frankly, we subsidized our small hospitals out of our big hospitals. It wasn't really hard to do. I don't know, Lynn, does that happen with Presbyterian in New Mexico particularly? I think that Press might have done that a bit.
No, they did it, so they're trying to do it.
Yeah.
They're trying, but it's not as the Pres that link up in the more rural communities. They
Yeah.
want to do it on their own. They want to carry the name, but not the enterprise piece.
You know, it's the interesting thing. I sometimes worry because it's so heavily mission-driven, and I could easily imagine that mission shifting, and then that support for the population of our rural state disappearing. We also hit staffing for many years in many of those communities to get physicians in the communities. There simply wasn't enough volume of services to keep them going on a fee-for-service basis at any reasonable sort of a level, especially if you wanted call coverage. One of our hardest things was call coverage. You get somebody in a rural setting and they're on 24/7, they get no breaks. And that was as bad as anything, was just the burnout. So we would need to put 2-3 physicians just to have a reasonable call schedule. And it meant we had to subsidize fairly heavily, and we did, interestingly enough. Here's the big one, though. This is the area where I really specialize. I've called it clinical decision support. The way to think of it is a group practice without walls. How could you build a practice so if I'm the lone doc, right, out in Garfield, Utah, Panguitch, somewhere way out there in the countryside, so that you're effectively part of a 1,400 physician group at an intellectual level in terms of treatment experience. What we did was develop a series of tools. It's a classic quality theory, key process analysis, big, heavy clinical processes. Type 2 diabetes mellitus. Depression is one of the bigger ones. A whole series of chronic diseases in an outpatient setting. Same thing in an inpatient setting. Coupled with a centers of excellence strategy, we had a philosophy. It was a careful planning function that we needed to deliver as good a care in Panguitch If we were going to do it there, it needed to be as good a clinical outcome as if you were in Salt Lake City at a big quaternary level center, you see. And the question was, is how did you make sure that that happened the best you're able? It's always a combination of providing local services versus transport. So a very extensive transport network. But then what we did was go down through and identify key care processes and build evidence-based best practice guidelines for them. Technically, we call them shared baseline protocols or care process models. So if you were practicing as a solo practitioner in rural Utah, part of the Intermountain system, it means that for your diabetic patients, you'd have a full set of clinical decision support tools to help you organize the practice, track these patients even if they didn't come to the clinic, know exactly where you were. You'd have support from the larger team, including the specialists, to help back the whole thing up. And it turns out with that, well, that group practice without walls, part of a large peer group, you could deliver as good a care in that setting as you could in the city. As a natural extension, it's the same thing we had to do in the big urban areas to deliver excellent care, but it was then relatively easy to extend it out into these other circumstances, you see. The other big piece that's really been emerging lately is this idea of telemedicine. That came up earlier too. It's not just electronic ICUs, which work quite nicely. One of the real fun ones is electronic pharmacy. Most of our rural facilities can't afford, they just don't have a fully trained PhD pharmacist to organize their pharmaceutical services. Initially, you had these circuit riders who go around and visit various places at various times. These days, it's much more likely to happen out of a larger facility on an electronic basis, and it's quite useful. Oh, one of the really cool ones, Eddie Stemigen, who's adjunct faculty here at the moment, runs infectious disease across the entire rural system. So specialty support in infectious disease to a level that frankly we've never seen before. Working through the local hands, but with that centralized expertise. Electronic support for ED. Now it takes a good transport network, but more than that, it takes an organized system of care for how you think about care delivery in general. And you do need it for high quality, low cost care in any setting or an urban setting. But then we were able to take what would build at scale in the big systems, and it was relatively simple to extend it out to support dedicated people in those rural environments. What I really heard from your presentation, Alan, was leadership, is what I really heard. I saw a dedicated clinical leader making stuff happen. I think that if you had a dedicated clinical leader making stuff happen in a rural community and you backed it up with that kind of infrastructure, that we could greatly extend your reach.
We went to Kaiser and they weren't interested. I should have gone to them.
You know, it's funny, a few years ago I was at Alvera Health in Sioux Falls, South Dakota. They haven't done as well on the full-blown shared guidelines, shared practice guidelines, care process models as we had. But wow, they built a wonderful telemedicine network. Frankly, they see it as a source of patients for their tertiary level care, coupled with a very effective helicopter-based, ambulance-based transport system. And they have wonderful, wonderful results. Now, they're going out of Sioux Falls, South Dakota, kind of toward the eastern end of South Dakota, all the way across Montana. So a very large geographic footprint, but then through electronic means, supplying services in some truly rural areas. But that was the idea. You know, David Eddy, when he was here at Stanford, I credit David, he really invented evidence-based medicine, guys. He's the first guy to use that term in the published literature. He developed almost all the formal methods we use for it. Sackett and others popularized it broadly, bless their hearts. I'm not sure which is more important. But David Eddy said it nicely. He said, the complexity of modern medicine exceeds the capacity of the unaided expert mind, regardless of setting. Truer thing was never said. The evidence supports that conclusion dramatically. One of the key things you'll see in any system today is knowledge management. How do you extract the relevant medical knowledge around best practice? How do you package it and then deploy it into point of care patient contact? And then during that same patient encounter, how do you extract the data back about what happens so that you can not just hold yourself accountable for excellent care, but also systematically improve so that you can adjust to the local resources, local circumstance of a particular community. I believe that this is going to be one of the major tasks for the healing professions in this next generation. It's absolutely clear the complexity factor moves well beyond the capacity of any single human being. I don't care how well trained that physician is, how dedicated they are, how smart they are. It's beyond that capacity. And I think it's going to force us to bump it up to an organizational level just to handle that scale, that level of complexity. So I think what we'll see is the emergence of those kinds of organizations. For years, I had hopes it would be professional societies. That was very disappointing for 20 years. Now they're starting to catch fire a bit. Now they're actually starting to get some traction, maybe. In the interim, though, I think it will take organized care delivery systems to support an effective, dedicated frontline team. But with the tools that we have today, rural takes on a whole different meaning, doesn't it? You see? Frankly, 40, 50 years ago, when I was out on the ranch, down on the farm, I don't think it's as isolated as it used to be. And I think with each passing year, it'll become even less so. I think that the distances are closing with the communications technologies that we have. And if we can take advantage of that, I think it will serve, well, our research interests well. I think it'll serve our institutions well, but particularly I think it'll serve our patients well.
Very quickly, key goals of the Affordable Care Act were to expand coverage, slow the growth in healthcare costs, and reform the health insurance marketplace. I'm going to give you some data about the extent to which health insurance has grown. But if you were looking back in 2009, before the legislation was passed, and looked at rural areas versus urban areas in the U.S., what you would have found was that uninsured, as Arnie alluded to, the share uninsured in rural areas was higher than in urban areas. And I'm also going to talk a bit about Medicare at the end of this, because Medicare policy matters differentially in rural areas too, because the share of the population that's 65 and up in rural areas is higher as well. I'm going to talk a bunch about the first of these areas, expanding health insurance coverage, a bit less about costs, but somewhat about incentives, and then finally about some possible changes to the health insurance marketplace. The program that I wrote my very first paper on when I was in grad school was on Medicaid, Medicaid here in California, known as Medi-Cal. Perhaps arguably the most significant change in the Affordable Care Act was the expansion of the Medicaid program. And it's a program that, as of before the Affordable Care Act, it was funded jointly by the federal government and by individual state governments to the tune of about 57% federal, 43% state. But the Affordable Care Act for states that decided to expand, and this map here gives you a sense of which states expanded and which states did not. And we have some variation here in the West. The states that chose to expand, people with incomes up to 133% of the federal poverty line could get coverage. And so the group most affected by this was childless adults. So if you were an adult and you didn't have kids and you were poor, it was hard to get Medicaid in most states. So the coverage was very low. But the Supreme Court ruling in June 2012 gave states the option. So as you can see here in the West, there have been some different approaches taken. So Utah, Wyoming, and Idaho elected not to expand their Medicaid programs. And there were pretty dramatic differences between what transpired in the subsequent years between those states and other states in the West. Montana came on board 1 year later in 2015, and then you see the rest of the US. But I'm sort of treating here, and Alaska is a state that expanded as well. I don't count Hawaii as being in the West. I don't know that, but Alaska kind of counts. So I don't know, how do we think about this? Okay.
We go all the way.
Do you go to Hawaii?
We go all the way to Australia.
Okay, Australia. Okay, great. And so this is, and it's quite remarkable to me, and I'm just going to give some statewide data here first, and then do some zooming in at a narrower level. but it's quite remarkable to me how dramatic the change in insurance coverage has been just over the last few years in these states. So if we look, and New Mexico kind of stands out, they win the prize for the biggest change. And you can tell me if this numbers sound right, but in 4 years ago, 4.5 years ago in New Mexico, 22% of the population was getting their health insurance from the Medicaid program there. And within 3 years, that went up to 37%. That is a pretty dramatic change. Here in California, a pretty big change, 24 to 31. In Montana, quite a significant change, 50 to 24. Now, if you look, there are 3 states that I highlighted earlier that did not expand their Medicaid programs. Very little increase in Medicaid coverage there. So Utah, I think, now wins the prize nationally. Utah or Wyoming, I can't remember which, for the smallest share of its population that is on the Medicaid program. That's partly a function of economics. It's partly a function of fewer people in Utah being below 133% of the poverty line, but it's also for sure a result of this decision not to expand the Medicaid program. Why does health insurance matter? I mean, I think there's a lot of evidence out there suggesting that if you have health insurance, you're going to get better health care, better access to care. Certainly financially, you're going to be better off in the sense that there's tons of evidence suggesting that people's credit scores are much better, all else equal, when they have health insurance than when they do not. And so, it is, but there's trade-offs. It's like, it has benefits, but it also has costs. It's expensive, and it potentially, Medicaid is, and I think one thing to note with Medicaid that I should have emphasized earlier is that Medicaid is not one program like Medicare. Medicaid really is 51 different programs. So Medicaid in Utah is different from Oregon, different from Montana, different from Alaska, different with respect to what they pay their providers, different with respect to the role of managed care, different with respect to what services are covered. I mean, in general, if you get hit by a car and you're in any of those states and you're on Medicaid and you show up at a hospital, the hospital's going to get paid, but the details of that vary massively across the states, how that will work. And so that is, I think that's worth lingering. And if you do zoom in, I'll give you some data in a second, but if you do zoom in on these states in the West in terms of rural areas, those Medicaid coverage numbers, those are statewide, understate Medicaid coverage on average in the rural areas. So if we were to go into rural New Mexico, if we were to go into rural Montana, we would see even higher rates of coverage on average for Medicaid. The other big part of the Affordable Care Act was the creation of health insurance exchanges that started up in late 2013. And there are, these exchanges have, just like with the Medicaid expansion, states differed a lot with respect to how they structure these marketplaces. So here in California, we have something called Covered California, which is totally state administered. And whereas in Arizona, they're using healthcare.gov, which is the federally facilitated marketplace. And then we have hybrids. I believe in New Mexico, there's a state-based plan, but they're using the federal. I'm looking to the New Mexico, but there is. I'm sad to say I've never been to New Mexico. I really want to go, but I've heard great things about it, but I've not been.
An open invitation.
Yeah. Okay. Great. So it is, but you can see that there's quite a bit of variation with respect to the states. And one thing that's very interesting across the states, if you look. So states have chopped themselves into regions for the purposes of these exchanges in different ways. Some states have called each individual county a market, and other states have required rural areas to be bundled with bigger urban areas nearby. So, and that has tended to work better for rural areas. If you're a rural county with a population of a couple thousand, you're going to have less success at attracting insurers and getting good products and getting good prices if you're on your own than if you're bundled with a nearby urban area. And so what I've found in some earlier research is that when rural areas, for the purpose of these ACA exchanges, were bundled with nearby urban areas, if you compare it to different places, they have significantly more options in terms of insurers offering coverage and lower prices, all else equal. So this is a big difference, and I think it really matters for rural areas because despite there being fewer options in rural areas, despite their prices being relatively high, enrollment in the exchanges is actually higher in rural areas than it is in urban areas within the same state. So it is the ACA, both with respect to the Medicaid expansion and with respect to the ACA plans, matters differentially in rural areas. And if you look, It's interesting too that if you look at states that did versus did not expand Medicaid, exchanges are much more important, and this is reflective of a national trend. They're a much bigger deal in the states that did not expand Medicaid than the states that did. That is partly mechanical. If you're a state like Idaho or Utah or Wyoming, and you're not eligible for coverage through an expanded Medicaid program, you're going to be more likely to go into these exchanges. And so Utah is actually among the highest. I think Florida is the state nationally with the highest share of its residents in the exchanges. It's almost 10%. And if you divide this instead of by the population, by the non-elderly population, which is the more appropriate denominator, because elderly people are really not in these exchanges, these numbers, you kick them up by about a quarter. So let's say a number like 4% would really be 5%, a number like 7% might be closer to 9%. You can see that there's much, 3 of the 4 states with the highest exchange enrollment in this list are the 3 that did not expand Medicaid, whereas the 3 states with the lowest Medicaid coverage back here in this list are the 3 states that did not expand Medicaid. So that is an example of a policy lever at the state level that is that had a very significant effect on the kind of coverage that people are getting. And you can see that the reductions in, so this is a different kind of coverage. Well, maybe this is just reflecting a different kind of coverage and the consequences for overall coverage are not very different, but you see very big differences across the states with respect to the share of the population that now has health insurance coverage. So this plots, the latter 2 columns give you the share of each state's residents without health insurance in 2013 and then in 2016. You see New Mexico, the biggest reduction, 11.2% reduction in the share uninsured. California right behind it. All of the states, so the 9 states in this list with the biggest reductions in the share uninsured are the 9 states that expanded Medicaid, and the 3 with the smallest reductions in the share uninsured are the ones that did not expand Medicaid. So it is, this has had big consequences, and once again, if you look at this instead of at a statewide level and you zoom in on Western states, the same category of Western states, and you look at rural counties versus non-rural counties, Medicaid coverage is definitely higher in the rural counties than in non-rural, and exchange enrollment is higher in those places as well, 5.1% versus 4.7%. And the share uninsured is about a third higher, so it's about a little bit less than 18% versus more than 23%. This latter number reflects the data that is pre-ACA, this share uninsured. They don't have the more recent data yet at this disaggregated level for the share uninsured, but it is, so that there's a bigger scope for the ACA coverage increases to have to really move the needle on coverage, health insurance coverage in these places. And it is, one of the challenges, as I mentioned, in the rural areas is in general, they have fewer options within a state than their larger urban counterparts. But then there's also some states that have seen very little interest from insurers, especially, so if you look in 2018, there's only 1 private insurer operating in the ACA exchange in Alaska and Wyoming, and just 2 in Arizona, Nevada, and Utah, and this is versus, let's say, 5 in Washington State, 7 in Colorado, and that's partly a function of bigger population, but it certainly wasn't the goal of anyone who was involved in working on this to have any state with literally 1 option for people to choose from. I mean, part of the goal with this was to give people choice so that they had a number of things to compete on price. And that's just high level on Affordable Care Act. I also want to call out some stuff about Medicare policy because I do think it matters so much in rural areas because the share of the population that is above the age of 65 is quite a lot higher. Once again, it's about a third higher in rural areas than in urban areas. And I've talked with Arnie a bit about this during my time at Stanford, this interest in this idea that many rural hospitals in sort of isolated areas are treated by Medicare as what are called critical access hospitals. So for these hospitals, if they're sufficiently small and in a small area, Medicare uses instead of its prospective payment system, which is designed to keep costs down and deliver efficient care, it basically uses cost-based reimbursement for both inpatient and outpatient care. And that's partly to help these facilities with financial challenges. If you're small and you're not operating at scale, it's pretty difficult to be at risk for the possibility that you have a really expensive patient who comes in where that capitated payment isn't going to cover, it's going to wipe you out potentially. But so that's good, it provides protection to these smaller facilities, but it also distorts incentives potentially because then you're getting rewarded when you're providing inefficient, high-cost care. And research has definitely shown that reimbursement is much higher than it would be under PPS. And part of the reason that this exists and that it's as common as it is, so many, think about 60% of hospitals in rural areas are designated critical access hospitals, is that by basically, in order to get this special treatment, this cost-based reimbursement, you have to offer both outpatient care and inpatient care. And some of these facilities are sufficiently small that it doesn't make a lot of sense for them to be offering inpatient care, but if they give that up, then they put themselves at, they're gonna get less reimbursement potentially. So there are some options that are possible in rural areas to deal with this, but one of the things that when I talk about problems with Medicare, people will say, oh, well, Medicare Advantage, which is the private option. So if you're in Medicare, you can either get fee-for-service Medicare traditional, or you can enroll in a private Medicare Advantage plan. Maybe those insurers are better at disciplining these hospitals and keeping their costs down. But if you look at Medicare Advantage coverage in rural areas, it's very low. Like insurers, once again, just don't have a lot of interest don't appear to have a lot of interest, or the people living there don't appear to have a lot of interest in enrolling in those plans, so it's much, much lower. The more rural the area, the lower is the proportion of the people there who are enrolled in Medicare Advantage plans, or at least it's true at a high level. So, but there are options in these rural areas that policy levers that could move around that could facilitate this, that would allow some of these facilities to specialize and to move to treating outpatient only, maybe cranking up their reimbursement somewhat, but that might improve their incentives while potentially reallocating inpatient care to other more efficient hospitals nearby. And this could lead to potentially better care in the sense that more, I mean, the causal, what is the chain of causality in the volume outcomes relationship, I think is still in dispute, but it is true that high volume providers, all else equal, tend to have better quality than low volume providers. And maybe this kind of reallocation could lead to better treatment. So that's just a high level on some of the things these are Medicare, Medicaid, ACA stuff that is sort of how I think about this. But I don't have the luxury of having sort of a perspective from the front lines, which I really appreciate in the first assignment and stuff there.
Let's see. So one of the things that Stanford emphasizes is teaching faculty how to teach, and among the things that you take away from those courses is don't just talk at the class, ask the class to get the class to engage. So who among, rather than my asking questions to the panelists, I'm going to rely on the audience to comment and ask questions. And why don't we begin with, why don't you start? And please, if you just introduce yourself when you speak.
Hi, I'm Phil Polikoff. I used to be at Princeton manager for 35 years. National medical audit. So there's a long history. Two questions. One, more directly into why choosing wisely, which you're very familiar with, really hasn't caught the attention. I just went back to their health affairs thing. And the choosing wisely is using the evidence base that was created by the American Academy of Internal Medicine, which all the societies, evidence base. It really hasn't captured the attention. So that's a concern to me. And then Mark, thank you for your comments. You talked a lot about the insurance exchange for reimbursement and all these different states. One, I did not know they were all over the map. And two, how does all these different things, is there any sense of quality versus reimbursement? And I know there's access to gas insurance, but is one state different from others? Is Utah and the other two you say have better or worse quality standards for their overall populations?
So, by the way, I want to make sure that everybody gets a chance to participate. So, which panelist would most like to respond?
To the first question.
You pick.
For the first question, just an observation, having worked on this many times. It's not a matter of just informing the physicians. There's more than you can load into your memory and remember and apply. We have a model of care delivery called pathway medicine where you load it all into the physician's mind and expect his memory to apply it correctly to patients. That we measured that or managed so that for adults we managed to do it correctly for things we know work and agree should be done. Do it correctly 55% of the time for children, 46% of the time. We tried that too at home. One was discharge medications for patients with heart disease, heart failure, ischemic heart disease. We tracked their numbers, we'd show it to them. We were actually the best in the country. We're at 57% appropriate use, which to me looks like a 43% defect rate. But we were the best in the country, what Jim Reinerson called being the cream of the crap. What we had to do was blend it into workflow so that it didn't rely on human memory. It was the memory problem that was doing it. The first month after we did it, there was a little mechanism that the team used. 98% appropriate use. That was 450 lives per year, by the way, in Utah. Across 6 years, a beautiful study in Annals of Internal Medicine that reduced mortality rates by 450. About 5% percentage points reduction in heart failure mortality, 22%, 17% across a certain number of years. But the key is don't rely on memory. The trouble with I forgot his name, speaking of memory. Yeah, with the idea of identifying these things that we should remember to do consistently. What was the first? Not up to, but what was the name of the program about the stuff that we're not supposed to do?
Choosing wisely.
Yeah, it always pops back. It just takes a minute. Many of you experience this too. The problem with choosing wisely is it requires that I remember. And even though I agree with it, I support it, it's making it happen on a consistent basis. So what you end up doing is getting into workflows down at the front line and understanding those workflows, and then starting to design them so that it doesn't rely on memory. So that's just one idea.
Okay, very good. Why don't we have Sonu next?
My second question, you get a response.
I know, but I want to make sure everybody gets a chance to ask, and we'll come back.
Thanks, Arnie. Is it on? Is it?
And by the way, I'm going to encourage you to ask one question or a comment.
So the question is, we've talked a lot about the fact that there's inequity in medicine that's still what across our country today. The question is, how do we ensure or incentivize equitable medicine as a criteria for developing the solutions and deploying them across our country?
Could everybody on the panel hear the question? Okay. So who would like to? Alan, go ahead.
You know, it's sort of the process that I learned in 1995 when the IPA began, and I started to try to figure out what is this thing about managing care. And you know, one of the first things I did was go to a meeting where Frank talked, and it was this guy coming on, it was in Silverado in California, and he talked about standardizing care. So what I basically went into it saying, why would we be worse than anywhere else? There's no reason for it, but we need to shed light on what we're doing. And it had to do with measurement, it had to do with creating guidelines that the community owned. So you know, we could get a guideline on diabetes, which is where we began, but we needed to get buy-in on the guideline. So let's customize it and call it Humboldt's guideline. So it involved bringing clinicians in to do that. We ended up with something everybody agreed on, and then we measured it and fed back to people how they were doing, and were able to track improvement. It isn't enough to throw choosing wisely out into the field. You actually have to measure what's happening and feed back to people in order for them to be able to manage it. And then we moved to many other conditions. And in terms of, you know, one of the things is how to control costs. And rural areas do face, you know, the closest regional hospital nearby is a 3-hour drive over a pass that's often closed in the wintertime, or a 4-hour drive south with a road that washes out when it rains a lot. So it's not a simple thing.
Can I just add one thing on? Sure. This is a little bit of a personal soapbox. I don't say often. At one level, I don't like the concept of equity in the following sense, just in this sense. I want the care to be perfect for everybody. I don't want anybody to be equally deprived. I think the aim ought to be to make it perfect for every human being, if you see what I mean.
That was my question. We often create medical solutions that work inevitably when deployed the way they are. But we don't use equity as a criteria to develop the solutions we do, saying that it needs to work in environments where the nearest support is through a winter pass that's closed. So we often create solutions for those of us who already have privilege without giving enough thought to how will this actually be deployed in areas where that privilege doesn't exist, even internet access doesn't exist.
Right. One of the things that we're addressing in this session is cost control. And this is a story about Stanford and about Humboldt. So, and it ties into the choosing wisely question as well in a rural area. There was a study done that Stanford had a lot to do with called All Over the Map, and somebody used the phrase all over the map. But it was done by Lauren Baker and then a woman named Shannon Brown. That published surgical procedure rates by hospital district across California, all payer database, because it was the entirety of, because there was OSHPD, which has all the hospital discharge data. And Humboldt was an outlier in certain surgical procedures that I was well aware of because I had been fighting what I can deem sociopathic surgeons over doing things for quite a while, with some success. So what happened was we invited up Stanford specialists to speak to 3 audiences in the community. One of them were the specialists who pushed back and said, you don't understand what it's like to work here, blah, blah, blah. Then they met with the primary care physicians and said, the practice pattern in this rural community is out of whack. You're doing things that we're not doing in the big cities. And one of them was taking out normal gallbladders because people, when they ate a fatty meal got a bellyache, which is called biliary dyskinesia. And in Humboldt, it was a reason to take out your gallbladder, and at Stanford, it wasn't. So the primary care heard that. And then the third was to go out to the community, because we had organized the community around healthcare in something called the Community Health Alliance, to attend the same meetings. And what followed those efforts, the 3-pronged effort, was a precipitous fall in inappropriate operations for all of the
Increase in
Inappropriate.
fall in inappropriate. And appropriate was not to do too many carotid endarterectomies. So that's how you make choosing wisely into a real thing. You can't simply throw out we in Washington or wherever choosing wisely came from. I know Daniel Wilson, who's the guy sort of in charge of the choosing wisely. And it was issuing through the medical, the different societies, guidelines. Well, they're great. They sit on a shelf somewhere. As Brent said, they're not front of mind. And we needed to get all the audiences, the patients, the primary care docs who were making the referrals, and the specialists who needed to be, light needed to be shined on what was happening. And it worked. And I don't know that you could have done that in an urban area, where you could bring patients together and all of the primary care community together. There's a charm to the tribe that I think can outperform the urban areas where competition gets in the way and people don't actually know each other across sectors. So I think my goal in terms of equity was we can actually outperform you. And despite poverty, despite high rates of drug addiction, despite some communities with 50% unemployment rates, and we succeeded.
So earlier, President talked about, I got the small version here. President Hennessy was here at lunch, and in his remarks, which were brief, he said we should be thinking about big data and maybe even AI. And I just wondered, is the med school thinking about this train? That you were talking about memory and creating networks, et cetera. And obviously, this isn't something that's going to happen right away, but building towards the future, it's clear that AI is going to get more sophisticated. It's not there now, but it's going to get there. The ability to put a lot of these records into major databases to help with diagnosis is going to get better over time. Is that something that we're working on here? Is that an area of specialization? And if so, is that possibly part of the solution in the rural areas where we have very dispersed?
So I want to articulate what, an illustration of what's already happening as a result of Stanford research, particularly as it would directly affect cost, quality, and access. And then for the second part of your question, defer to the panel in terms of is this ready for for clinician uptake. But one of our faculty members here at Stanford, Nigam Shah, began to realize that people like Alan and Brent, who've taken accountability for improving cost, quality, and access, one of the things that would really help them and the clinicians that they try to in turn help is to better anticipate which members of any population in the subsequent year were going to comprise the 5% that would account for 50% of the spending. And what's intriguing about that 50% relationship is that 60% of them were not high spending in the prior year. So simply, what we knew, I was a co-investigator here, what we knew is what the insurance companies in the United States were doing was crazy, because they were focused on trying to pick out who of last year's high spenders would continue, but that wasn't where the majority of the money was. And so we together, step one is get a big enough population database that you need to apply machine learning to be able to look at 2 years worth of data and train an algorithm to predict who's going to newly enter this high cost group. And we were able to show that using artificial intelligence machine learning methods, we could substantially better identify the people who would newly ascend. It was published in British Medical Journal a couple of years ago, and now there are now commercial companies running with it. The Stanford translational engine works well. And then the other opportunity that I know is actively happening in terms of using artificial intelligence to actually improve healthcare is actually occurring in a research partnership with Intermountain Healthcare. It's a collaboration of the Stanford Engineering School, the medical school, the two adult hospitals here, and Intermountain's LDS hospital in Salt Lake. And there we're focused on a different part of the cost quality problem, which is once you are clear on what you want to happen at the bedside, particularly in hospitals, but eventually in outpatient clinics or in patients' homes, could you imagine an economical artificial intelligence system that would be able to metaphorically tap clinicians on the shoulder and tell them, there's a very important part of the intended care pathway that you are now on the brink of either forgetting to apply or misapplying. And so we started with something really easy, which is when hospital staff enter a patient's room, do they use that alcohol dispenser at the doorway? As you probably know, hospital-acquired infections have proved to be a very intractable problem across most of American healthcare, both rural and urban. And one of the problems has to do with the rate at which busy humans overlook using that alcohol dispenser when they go into patients' rooms, and then bad things happen. And I'm a trustee I'm on the board of a number of hospital quality committees around the United States. And it's funny, I feel badly every time some clinician leader steps up and says, our goal is zero hospital-acquired infections. I know they're not going to make it because of some of the limitations in human wiring. And so what we've already shown in our research, just using this single target, is that we've been able to train what at scale would be a very economical computer vision system, a computer vision technology-based system to correctly identify use or non-use of that alcohol dispenser before a member of the clinician staff enters the room at 95% accuracy. And that's just first year out. And that is not so much a credit to me, although I'm a co-investigator, but that's really Fei Lee and her team at the computer vision lab at the engineering school. So the answer is yes. And there are other teams that I haven't had a chance to talk about that are also making major strides, not so much in use of AI, on the Stanford campus, but this different use of AI to actually improve the cost and quality of care. Fred?
I always feel I'm participated a bit in and really fascinated by what some of the CERC teams are doing. There's another one out there that I personally believe is going to have huge impact. Currently, only about 20% of all information captured in a clinical environment is computable. It's captured in a form that a computer can translate or use. It means it's completely outside the realm of any deep learning or machine learning. There are some new things happening that will probably push that up very close to 100%. At the same time, it will dramatically make use of EMRs easier for clinicians. It's a major sore point right now within care delivery operations, and arguably be the ideal platform for deploying knowledge support to the front line. And so there's some things on the IT side and the computer science side, and I think it's going to fundamentally redefine clinical practice. So the sorts of things Arnie's talking about just got a lot better.
And just in terms of the Stanford campus, we have a number of faculty who I don't have time to name, who are actually working on this problem that Brent named. That is, how do you use AI systems to translate unstructured text entries into electronic health record into structured data. And that's being done both for spoken language, natural language processing advances, all happening here on this research happening on this campus, as well as advances in text mining, text data, and those are two more illustrations of how AI might be used to advance cost and quality, and significant progress is being made not only here but among some of our colleague institutions around the country.
Can I speak to that?
No, I just not because I want to make one. I want to give a chance. Go ahead.
I just have one, if I could, one sort of comment about the Medicaid piece from a rural perspective, and then sort of a question for the two of you. But on the Medicaid piece, one of the barriers that we see in rural communities is Medicaid delays in, not necessarily the rate, but that there's a delay in the reimbursement.
Yeah.
And so I just wonder if there's ever been anything looked at from urban versus rural, and then for you two, I want to ask it, but
Not that I mean, in the extent to which Medicaid payments are delayed, is there a difference between rural and urban areas?
if it's really been looked at, just to say, is there a disparity between reimbursement rates in urban versus rural?
I think the rates, yeah, Medicare rates are somewhat different in rural and urban areas, and I think it's the case for sure that there's providers respond to those rates. Their behavior will change if the rates are higher or lower. But I don't know of something off the top of my head that looks at the urban-rural difference, but it's big in New Mexico, as you know.
It is.
If you're there, yeah.
One last question.
And then quickly, sorry, I just wanted to say, so in New Mexico, we have my chronic disease, so my CD program, which is a self-management diabetes program. But one of the challenges is, and it sort of goes into what Intermountain does, and I wrote a note saying, could we create a system of care? In the health department, I operate 5 24/7 facilities for safety net populations, but one of our challenges is interoperability. So has that been considered as far as, so even with our self-management programs, we have a very transient rural population and they move around a lot and they don't necessarily take their information with them when they go. And so is interoperability in a connected system of either my self-directed care versus a system of care or a consideration?
So the short answer on that is that the new systems that pull so much into computable data, they use a new type of representation of knowledge. They're called context-sensitive semantic models. Perhaps because it's a new field, it will solve the interoperability problem. It means that everybody will be on the same basic standard in terms of how those data are represented. And then it will just be a transmission problem of how do you move it from place to place, which is frankly a much easier problem.
And what we did was, and that strange diagram I showed you with all the connecting lines, we started a North Coast Health Information Network that not only allowed people to transport records from one system to another, and because we were in an IPA land instead of an integrated system, and choice is perverse, no two practices ended up with the same EHR. So what we had to do was come up with an infrastructure that bridged that. And not only did we do that successfully, which included an e-referral system, we were able to tie in justice and education and social services into the database. So now wherever you go within the county, your records follow you, certain parts of your records follow you. And if you are on Medi-Cal, California Medicaid, and then you're arrested and you're in jail and then you drop off of Medi-Cal because it's now the county's responsibility, we can track that person across multiple databases with a master patient index. So in fact, in a rural area, the information, I think, at least we've shown is it's possible that actually outperform urban areas in that regard.
Well, I'd like to thank our metaphorical class for great questions. Please join me in thanking the panel.